Hi, everyone, and welcome to our UK Hangout. This is a weekly hangout that we have through the Global P.A.D. Association with some incredible friends throughout the United Kingdom that all have poor circulation in their legs, known as P.A.D., and are wanting to thrive. We are starting a new series in conjunction with our weekly hangout where we're going to start talking about a lot of the trials that are happening for peripheral artery disease in the UK. And we have our amazing advisor, our luminary of the year for 2024, here with us. And he's got a lot of trials to talk about. He is spearheading so much incredibly impactful research for peripheral artery disease. Dr. Thanos Saratzi is academic vascular surgeon. We really appreciate you joining us. Thank you. You're participating in our padtrials.org. You've offered the first set of trials that are available for patients to learn about at padtrials.org. So thank you so much for being a pioneer with this to democratize access to these trials for all patients across the UK.
Fantastic. Thank you very much for the invite. And it's my pleasure to help patients and help progress healthcare practically.
So where should we start? You have what, 5 or 6 trials that we have already that are on padtrials.org that so many people have questions about. So they wanted you to come here and provide some details. I know you have a slide deck that you want to go through that can provide a little extra support here with information. So why don't you get started?
Yes. So I'll share my screen. So like Kim mentioned, I'm a professor of vascular surgery. I'm based in Leicester, and I'm one of the vascular surgery specialty leads for the United Kingdom through the Royal College of Surgeons. So I'm representing a number of colleagues today, and I'm just going to touch on a few basics about important studies regarding P.A.D. or peripheral artery disease. And I'll try and use lay language as much as I can. So let's go through these slides for a minute. And as I said, I'll start from the basics. So P.A.D. is a condition where you've got blockages or narrowings in your leg arteries. The risk factors might be known to most of you. There are things like high lipids, smoking, a high blood pressure, genetics as well. And we need to address as many of these risk factors as we can. But obviously, the other thing that we need is evidence or research as to how we best address those risk factors. So P.A.D. is a very common problem worldwide. It affects about 20% of people above the age of 55, and it's associated with things like diabetes, multiple long-term conditions, and socioeconomic deprivation. And that's the case across the world, not just in the UK or the United States. And there's a spectrum of symptoms when people have got P.A.D. Many people will not have any symptoms at all in their legs. Then many people will present with something called claudication, which is pain in the calf or the buttock when you walk, and that's caused because of poor blood supply. And then other people will present with big ulcers in their legs or pain throughout the whole day. And this is called CLTI, or chronic limb-threatening ischemia. And that's a major problem because CLTI might lead to amputation or even sometimes death if it's not treated in the right way. Now, clearly, P.A.D. is a big health issue. A few years ago, we got together about 100 patients from across the UK and a number of healthcare practitioners like surgeons, radiologists, podiatrists, and these were people from across the UK. And we did something called a priority setting partnership. And we tried to identify through surveys and interviews the key questions when it comes to research in P.A.D. So what are the key things that patients want us, the doctors, the nurses, to find out regarding their condition? And I know this is a very busy slide, but these are the 10 questions that the patients found out are most important for them in terms of research. And what were those things? There were things like, what can we do to improve outcomes when people get surgery for PAD or when people are offered certain medications for PAD? They also wanted to know what the optimal exercise might be for PAD and how can people access that exercise a bit better. There were also some questions about diagnosis and education, both for the doctors, the nurses, as well as the patients. And interestingly, quite a few questions about how we slow down PAD and how we can reduce leg pain without surgery. So in a nutshell, 2 or 3 years ago, patients from the UK found these 10 questions to be of the highest importance to them in terms of the next research projects that we need to fund and deliver in the NHS. So how do we answer these questions? Obviously via research, and the highest quality of studies that we can deliver for these patients and these questions is RCTs. What does RCT mean? It's a randomized controlled trial. So in an RCT or a randomized controlled trial, we find some people who are willing to take part in a study in order to ask or answer, if you like, a certain question. And we randomly allocate them to at least 2 treatment groups. So group A, which gets treatment A, and group 2, which gets treatment B. Then we follow them up for a number of months or years, and we perform a number of analyses to look at which treatment is better. And we figure out which treatment we should be offering to those people in the future. So in a nutshell, this is an RCT and is the highest quality of study that we can perform in order to address one of the questions, like the questions I showed you earlier, when it comes to a certain disease area. The first study of this nature was actually done many years ago, and I like showing this to patients because this chap called James Lind, back in the 18th century, took 12 sailors with scurvy and he randomized them. He randomly allocated them to get one of these 6 treatments to treat scurvy because no one knew how to treat scurvy back then. And he found after a week that group 6, the people who got the oranges and the lemons, were actually healed, but the other groups didn't see any change in the symptoms. So he figured out that the treatment for scurvy, or at least the best one, must be eating oranges and lemons. And that's how we found out regarding the association between vitamin C and scurvy. So this was the very first RCT. Now, unfortunately, and this rings very true to today, what James Lind did next, he made a living selling the treatments that were shown not to work in these RCTs. And in many ways, we keep making the same mistakes because sometimes we do get RCTs right. We do get the right answer for certain questions, but we still don't use our own RCT findings because we probably as healthcare professionals keep saying that some of these studies were not designed correctly or they didn't have enough participants. So one of the main reasons why I'm here today is to try and convince patients like yourselves that really you should take part in those studies so that they're big enough to answer the questions in a robust way so that no one can doubt what they show. Because at the end of the day, these RCTs are the gold standard, the best way to show whether treatment A or treatment B is better compared to all the treatments. Now, we do have to use our brains, though, sometimes when we look at the quality of these RCTs and when we look at how people have designed them. So I'm putting this slide up here because lots of studies in PAD have not included enough patients. And the very best study you can do in order to look at whether a treatment works or not is something that we call a phase 4 study, where you've got hundreds or even thousands of people taking part. And these studies are rare in PAD, and that's really unfortunate. Because if we don't get those big studies delivered, we cannot tell whether a treatment works or not, and people will keep losing their legs or even dying due to PAD. This is another busy slide, but what I'm trying to show here, look at coronary artery disease, look at stroke, which is called cerebrovascular disease. All these people treating heart attacks and strokes, they've delivered these massive studies and they've got the answers that they need for most of their clinical questions. But when you look at CLTI, which is as big a health problem as heart attacks and strokes, we've only really delivered 3 big studies, 3 big RCTs in the last 20-25 years. And that's a real shame. We need more of these studies in order to be able to guide how we offer people the right treatment. So again, that's another reason why I'm here today, to try and showcase this massive number of trials that we've now been able to fund across the United Kingdom. So I know again that this is a busy slide. You can find details about many of these studies, as Kim mentioned, on padtrials.org and Vascular Research UK, which is another website that gives you links to these studies. And what I've tried to do here, I'm trying to show you that there's a study for pretty much every patient who has got CLTI and might need surgery or might need medications in order to treat their condition. These are the key latest RCTs relating to CLTI in the UK, and I'll just mention them very briefly. The EVOCC trial is looking at the best type of surgery if you've got blocked arteries in your tummy or your pelvis. The KID trial is looking at which artery dye is the best one to use when you get an angioplasty, a balloon treatment for your arteries. These other 2 studies are looking at medications. Clarity is looking at which one is the best blood thinner after you've had surgery for P.A.D. or CLTI. And P.A.D. is a study that's looking at whether colchicine, a very cheap drug, can prevent heart attacks and strokes in people who have P.A.D. All of these studies are open for recruitment at many sites in the UK. Your doctor, your nurse can signpost you if you feel that you might want to take part. And can I just say that things like the P.A.D. study, that's really straightforward. You are randomly allocated to either get the colchicine or a tablet that looks like colchicine, which is called placebo. And most patients with P.A.D. would probably be eligible to take part in this study. These green highlighted studies here are opening in early 2026, and they're looking at the best ways to offer surgery in order to open up the groin arteries or the arteries in the thigh. So I'm not going to spend too much time on them. They're coming up within the next 6 to 9 months. So in general, you could argue that these RCTs in the UK are split in 2 groups. The group that's looking at medications, so tablets like P.A.D. and Clarity, and the group of studies that are looking at the best ways to offer people surgery. So if you're about to have some form of surgery for P.A.D., you might want to look into one of the surgery trials. If you've already had surgery, you might want to look up the P.A.D. and the Clarity trial. Or if you've got pain when you're walking, which is called claudication, you might want to look at the P.A.D. trial. So how can you take part? I get asked this question many times. If you see a vascular surgeon in clinic, they will know how to signpost you and suggest the right people to speak to. If you are seeing a radiologist, the X-ray doctors who do the angioplasties, again, they can signpost you accordingly. Or if you're seeing a nurse in a clinic, again, they will know about these studies. Some hospitals in the UK might not be open for one of those studies, but you can still ask your surgeon or your nurse about them, because they might be able to refer you elsewhere, or they might pick up the phone to someone like me and say, do you want to see this patient? They might be interested in your study. This is a QR code which you can scan with your phone, and you can download the summaries of those studies, not in lay language, but in language that you can show to your doctor or your nurse in case they haven't got a wind of the studies that we're talking about. So that's all that I had to share. I know that's been quite a bit. I've tried to keep it as simple as I can. You can find out a lot more on the relevant website, and please do scan the QR code if you're interested in the very extreme detail of those studies. The key message from me, if you have got P.A.D, there might be a trial for you out there. Next time you see your surgeon, your radiologist, your nurse, why don't you ask them about it? And they'll be able to signpost you accordingly.
What we have found is some of the doctors in the community hospitals don't seem to be in the know about these studies. Is it the responsibility and a requirement in the UK for all doctors to be aware of these studies?
As vascular surgeons, the General Medical Council, that's the governing body of surgeons and doctors in the UK, we are actually obliged to offer people the chance to take part in these publicly funded trials. So that's why I'm saying that if you speak to your doctors, and some of us might be unaware of a certain study. I mean, that's human nature at the end of the day. We can't know every single thing, right? But if you do ask them, they can go online, they can visit your website, they can visit Vascular Research UK, and they'll be able to signpost you accordingly. But indeed, that's a real problem. Some doctors out there might not know that much about these studies. I think the vascular surgeons, the radiologists, the specialist nurses are the ones who are far more likely to know about all of these studies.
And would you mind going through? I would love to go to P.A.D trials and just go through in just short and give people a little bit of an idea the types of trials that we are looking at right now. So we can start maybe with the Clarity trial. Can we talk just a tiny bit about that?
Yeah, I'm just sharing my screen again. So this is the website that you've very kindly created. We've tried to provide a bit of a summary here. Let's stick to the Clarity trial, right? So Clarity is a trial led by my colleague and friend Chris Twine from Bristol. It's looking at blood thinners after people have had keyhole surgery for their leg arteries. So what does that mean? If you've opened someone's blocked leg artery, then that artery might block again, especially if you don't offer them a blood thinner. But we honestly don't know which blood thinner is the best one to use. Is it aspirin with clopidogrel? Is it one of the newer blood thinners? And the main one is called rivaroxaban, which really does thin down your blood, not just stopping your platelets from working, which is what aspirin and clopidogrel do. Or is it clopidogrel by itself? So there's various combinations that we can use. And this is a study that's comparing 3 different types of medications or combinations. So if you've had keyhole surgery for your arteries and you decide to take part in the Clarity trial, you're randomly allocated to one of these 3 groups of blood thinners. Then the investigators in the study, they will probably ring you, or you might come back to a clinic appointment, which would be part of your NHS care anyway, in order to figure out whether you've had more surgery, whether you've had a heart attack or a stroke, whether you've had an amputation, etc. So we're trying to find out exactly what happens to each patient in one of those three arms. And that's how, in the end, we're going to decide which type of treatment is best after these keyhole surgeries for people's leg arteries. So that's the CLARITY trial in a nutshell. It's got quite a few centers open for recruitment, I think at least 10 NHS hospitals. And it's a fairly straightforward study because all we're doing is randomly allocating people to one of those three blood thinning regimes.
And so what if they're not near one of those facilities that is recruiting? What if someone says, hey, you know what, I'm in Scotland, I'm in Glasgow, and there isn't a facility there. How does one of those patients actually participate? How does the doctor get the patient involved? And how do you rally that doctor and get them motivated to do what it takes to get that patient onboarded?
That's a very good question. And that's why, as I mentioned earlier, every study has got a team that leads the study and a chief investigator. So next time you go to your clinic, let's say, and you've already had a keyhole treatment for your artery, if you are interested in the CLARITY trial, the doctor that you see there will have the contact details of the study team, and the study team can facilitate how you might be able to take part in the trial. You might have to travel for once, or they might have to speak to you online in order to get your consent, etc. But it's something that's doable. And let's look at it from a positive point of view. Obviously, not every trial will be open in every single hospital in the NHS. But in the NHS, the care for peripheral artery disease is very centralized. We've got big hospitals offering these treatments. So I would say most people are likely to have seen a vascular surgeon in one of those big hospitals. And most of these studies are actually open in these bigger hospitals. So, yeah.
Let's go on to the established trial. That's really interesting. This is something that I know is near and dear to your heart because you shared in our interview when you were named as Luminary of the Year, Global Luminary of the Year, that there was a catalyst for this type of trial. Is minimally invasive better in some situations than open, and open better than minimally invasive? And you shared the story of a case about an iliac blockage.
Yeah. Yes, so this is an interesting one. Has recently been funded by the government. My colleague who's leading this one is called Sandeep Nandra. He's an academic surgeon, much like myself, from Newcastle. I'm the co-lead, if you like, in this trial, but this is all Sandeep's work, and all credit goes to him. So in this study, which will open late this year, early 2026, we're trying to figure out whether the keyhole surgery to remove a blood clot from the artery is better than the open surgery. It will be a difficult trial to do because essentially we're comparing keyhole surgery to the very traditional treatment, and people have got very fixed opinions about how you should be treating blood clots that appear suddenly inside an artery. But I hope that with the help of groups like yourselves and patients, we'll be able to deliver that. So that's coming up next year.
Okay, what about the EVOCC trial? I think that's EVOCC.
Indeed. So EVOCC.
So is that similar? That's similar to the other trial that we just talked about.
Yeah, in some ways, because all of these trials are looking at various types of treatments for P.A.D. The EVOCC trial has been open now for about a year and a half. I'm leading this with.
So this is the one. So it's still it's
this
kind of
is the
similar,
one.
but this is the one that was driven by your iliac case.
Yeah, exactly. So this is the one we discussed before, and again, it's looking at people with blocked arteries in the tummy. Is a stent better than open surgery? That's what we're trying to look at here. We've already got about 210 patients recruited in this trial. We are behind in terms of recruitment. So if you have got this type of disease and you've been offered surgery of some description, then please speak to your doctor about the EVOCC trial. We've got another year or year and a half of recruitment left, and we're trying to get to 600 patients. And to give you an example, this is open in 32 hospitals now in the UK. So this is almost every hospital in the UK that's treating people who have got P.A.D. So going back to your earlier question, for some trials like this one, things are not very bad. They are indeed open in many centres across the United Kingdom. And that's what's brilliant about the NHS.
And, with this trial in particular, what I'm curious about is, are you disseminating between the cases in which a patient is hypercoagulable versus someone who has atherosclerosis that is blocking? Because, for example, we have
Yeah.
someone that's on here that was more hypercoagulable. And it turns out that just the right medications, walking is medicine, quitting smoking has really made such a difference in
Yeah.
that versus she was originally offered the open surgery, the aortic bifemoral bypass. And
Yeah.
then it turns out she goes to the other doctor and was like, well, nothing's really needed right now at all.
Yeah.
And so she avoided all procedures, at least for the moment.
So the EVOCC trial is for people where the decision for intervention, so the decision to open up their arteries, either with a stent or with open surgery, like the aortic bifemoral bypass that you mentioned, has already been made. So it's not the acute patients who just have a small blockage. It's the patients that have got those long, extreme blockages. And that's where we really don't know whether the stents do better compared to the aortic bifemoral bypasses.
So the decision's already been made as to what the doctor thinks might be best for them. And then they go ahead and do it, but you're able to look at, as you follow these patients in the trial, the differences in those cases as to
Yeah.
where the stent may have performed really well. We've had patients that we got a second opinion for here in the United States and that were up for an aortic bifemoral bypass. They ended up with a stent. Now, maybe a stent doesn't last for 30 to 40 years as maybe an aortic bifemoral bypass may, but there's always that contingency plan that at least they don't have a major surgery right now, and they can, get maybe 5, 10, maybe 15 years out of that one stent. Are those considerations in that, or is it, what is really the purely, is it just like, well, this one lasts longer than the other, so we consider the aortic bifemoral bypass the win?
No one really knows the question to this. The answer to this question.
Yeah.
We might say that aortic bifemoral bypasses last forever, but I mean, says who? We've never compared them to the newer stents that we've got these days. Then we also do say that these stenting procedures are far more straightforward. But actually, for the people in the EVOCC trial who have got multiple blockages, the stenting procedures take hours to perform with lots of radiation, lots of dye given in the artery, which can damage the kidneys. So it's not really a keyhole procedure in many patients when it comes to stenting. So for these more extreme versions of blockages in the tummy and the leg arteries, we just don't know whether the open surgery, so the bypass, is better than the stenting because both have got pros and cons. And that's what we're trying to address here.
That it'll be really interesting to find out, and especially the difference. It's usually, I think you're talking more about, people who've smoked that have the real atherosclerosis versus I find here that, again, the hypercoagulable patients where you could go in with a TPA and a little thrombectomy and the patient does really well beyond that on anticoagulant or dual therapy, for the long term. But a lot of times they don't check as to see whether or not it's clot or whether it's calcium. And that's kind of frustrating on my part because I think that those cases are fewer and far between. But it's just
Yeah,
something that it always
indeed.
crosses my mind when I talk to patients. I'm like, okay, so they want to do an aorta bifemoral bypass as frontline treatment. That's great. It does last longer, but what if it's just clot and you can go in with a TPA and a little thrombectomy and long-term, medical management, you're fine. And I think that it hasn't been addressed either. That people should make sure whether it's
Yeah,
clot or atherosclerosis.
completely agree. And again, with EVOCC, we're looking at the CLTI patients and those with short distance claudication. So these are the people with the calcified arteries, the long
Yep.
blockages, not just the ones who have got a bit of clot somewhere. And like I said, the decision has been made that practically, you need this artery to be opened somehow. Otherwise, you're about to lose your leg. So this is the population for EVOCC.
And people need to realize these are really big arteries. And
Yeah,
so
absolutely.
I mean, if you're talking 100% blockage there, a little wire and balloon, it may not be enough to really get that floodgate open to keep your legs alive. So it's a really important trial, and I look forward to those results. And if you do have a chance to participate, I think it's a really important one for everyone, if you can, to participate in that one, if it's right for you. Hamlet trial. What do you think about that one?
So Hamlet. Hamlet is looking at amputations. So some people at some point, if they've got P.A.D, they might need an amputation. And a common type of amputation offered to people is what we call an above knee amputation. So the level of the amputation of the leg is above the level of the knee joint. In more recent years, many surgeons have started performing through knee amputations rather than going just above the knee. But we don't know which one is better for patients in terms of pain, in terms of the subsequent rehabilitation. So Hamlet is a trial led by my colleagues in Hull. National trial as well has started opening up some sites for recruitment, looking at whether the amputation just above the knee joint is better compared to the amputation through the knee joint. It's a technical kind of trial, if you like. It's looking at the best form of amputating a leg near the knee joint. It's very patient centric because the outcomes that it uses are all relevant to the patient's quality of life and how they do after the surgery. So very important study for patients, because with these amputations, rehabilitation is just not easy, especially if you've had CLTI for months.
And this one, the KID trial, I find very interesting. It's so important for patients with chronic kidney disease and end-stage renal disease, because you're
Yeah.
talking about carbon dioxide versus artery dye.
Yes. So the KID trial, again, I'm leading that one through Leicester. Very easy study. When people need an artery opened through angioplasty, you use a dye that you inject in the artery, and that can damage your kidneys. If you use CO2, carbon dioxide, instead of that artery dye, which we call contrast, you can prevent the kidney injury or the kidney damage from happening. But that's only on paper. No one has ever tested that. So we've got only four sites right now in the UK. That's Hull, Leicester, St Thomas's and Guy's down in London, and we've just opened the study in Manchester. And all we're doing is comparing the CO2 to the usual dye. You only need a blood test at 48 hours after the procedure, and then we can tell which group of patients has had less of a kidney problem. We only need about 170 patients. We've got about 50 patients so far, and let's see how we get on. I think this is one of the easier studies to deliver because of the smaller number of patients that we need.
And if a patient wants to participate and their hospital is not participating, is it easy to get that referral to a facility that is performing a trial?
Yes, so discuss it with us, please. The email is kidtrial, one word, KIDTRIAL @leicester.ac.uk. And I'll
Okay,
put
we
it in
should
the
also
chat.
add that.
Yeah.
Yeah, that'd be great. And we should also add that. I should add that to the, I have them and I have people, I have our email on there, but I can also add that email on there, which I think is important. I hope you don't mind that I'm enjoying actually, and I think we have quite the crowd here in our live studio audience. And I think they would love it if you wouldn't mind just finishing off and going through the rest of the trials one by one. Do you mind?
Yeah,
I'm
absolutely. I
finding
can
it
do that.
really interesting. Okay. So next up, we have the placement trial, and we're talking about, and this one I haven't seen. So the local anesthetic infusion to help with pain management after leg amputation. We're dealing with a patient right now that had his leg amputated, and the doctors aren't sure how to handle the additional leg pain. Well, do we cut off more, or is there something more we can do? And I'm curious about this particular approach and what that looks like in the placement trial.
Yeah, again, very straightforward study. That's for people having an amputation. Again, the more extreme version of P.A.D, sometimes people might need an amputation. As you might expect, if you have had an amputation, and we're talking about below knee amputations or through or above knee amputations, so the bigger, the major amputations, you need some form of painkiller or some form of pain management system to be in place after you've had your amputation. And my colleague Dave Bosanker, who's leading this study, is trying to figure out whether using a local anesthetic infusion at the level of the amputation for the first few hours and days after the procedure actually does reduce pain and does make patients feel better and be more functional. It's open in many sites in the UK, I believe about 20 sites. So again, most likely, if you are being treated for severe P.A.D via an amputation, the site where you're being treated at is extremely likely to take part in this specific trial. So do ask your doctors about it.
And we have the RAF trial, the RAF trial. How is that different from EVOCC?
The RAF trial and the RAVE trial, they're two of our most recent studies. The RAF trial will open late this year or early next year, again, hopefully in 30 sites in the UK. It's looking at whether the keyhole or the open surgery is better for groin artery treatment. And the RAVE trial is looking at whether an angioplasty, which is the procedure to stretch an artery open, is better performed with or without a new catheter called lithotripsy catheter. So what does that mean?
The lithotripsy, the audio waves, right?
Exactly. Again, no one has tested whether these audio waves do indeed make a difference in people's life after the artery surgery. That's why we're doing this trial. And in fact, it was commissioned by the government. So the government said, this is something that we need to look into. So it must be a pretty big problem for the NHS. And I think that comes from the fact that these audio wave catheters are quite expensive. So the government wants to figure out whether they are making an important difference.
And so that's one that we don't have up on the website yet, the RAVE trial with the lithotripsy. I think we have the RAF trial.
Yes.
So we're going to need to add that one on there.
Yeah, I mean, it's only just been funded literally about a week ago. So, yeah.
So everyone, this is breaking news.
Yeah, indeed.
You're hearing that'll be up there very soon. So hopefully we'll get that up there this week. If you send me the details, we'll get that on the padtrials.org website so you can find out more. That's really interesting. Okay. So how about that RAF trial? So the RAF trial, is that different? So how is that different again than the EVOCC trial? One is just
Yeah,
more general that combines the abdomen and the legs, and then is that one just
yeah,
with the groin? That's just the iliacs, or is that the common
yeah,
femoral, bendy?
yeah. So RAF is common femoral artery. That's the
Okay,
artery in the groin. If you've only got disease there, the RAF trial is for you, because the vast majority of patients who have got PAD have actually got groin artery or femoral artery disease. So that's what we're looking at in RAF. In EVOCC, it's the bigger arteries above the groin, the iliacs and the aorta. And you can take part in both, by the way.
gotcha. Okay, that's good. I want to open it up, if you don't mind, to folks who are in our live studio audience. If you have any questions for Dr. Saratzis, in regards to these trials, how to talk to your doctor, even ideas, things that you're concerned about. One of the things that was, and I'll start while you're thinking of a question, if anyone has any. We did have one from Melody, who's in our groups, in regards to people. We're seeing more and more cases in which patients have been diagnosed with terminal cancer. They're marked with, being palliative and put on palliative care. But while they're on palliative care for the cancer, they end up, because they're laying in bed, right? And they're ending up with critical limb ischemia. And we just had a patient where they said, well, we're not going to worry about your legs because you're going to die of your cancer anyway. Well, then it became, they flipped the switch where they were able to say, well, you're going to live longer with your cancer. We're able to manage the pain with that cancer, but you're probably going to die of your legs, becoming necrotic and this sepsis setting in. In the meantime, there's no medication that is helping those patients in that situation with that sort of necrotic pain that it seems like no medication can touch. And that's something I don't think people expected. I don't know if that's something that is being talked about at the highest levels. Like, what do you do in these cases? I mean, do you just is that part of palliative care, to open up the blood vessels just a little bit, to get a little tiny bit more blood flow to make them comfortable in their final days? I don't know if it's something that
Um,
you've been faced with, but we've had 3 cases now in the
yeah,
last couple of months with this.
this is a very difficult situation and a very difficult question to answer. I think in those very difficult scenarios, we need good communication between the treating team, so the surgeons, the radiologists, the nurses, the patient, and their family, to understand what we're actually trying to achieve here. Because indeed, some patients might be so frail that they just need a bit of support for the last few weeks of their lives rather than go through major surgery. I don't know whether that's making much sense. There are some services in the NHS that are really good at doing that. And these are the geriatricians, the people who care for older individuals. And in fact, from Guy's and St. Thomas's, there's a team there called the POPs team, and they've created a package which does help those patients who have got many different health conditions to get through the last few months or the last few weeks of their lives in a way that will make them happier rather than just go through surgery, which might not really improve things for them.
That's good to know. It'd be interesting to get, because that wasn't information that was provided to the few patients that we've dealt with, and it was such a painful process, with the families not being able to handle, their family members screaming out in pain and no medication, cutting that necrotic pain that they were experiencing. So I think that, through us, we're going to help get that information that you just shared out there. But it is something that I think is a grander issue going forward as we see additional cases of CLI in these types of terminal patients. We have Kathy that has a question. Kathy, go ahead and unmute and ask Dr. Sarasis your question.
Hi there. Sorry, I put it all in the chat. When you were talking about not being able to recruit enough patients, my question really relates to the trials that involve walking, and showing the effectiveness of walking. I took part I didn't actually qualify for the clinical trial because I couldn't do the treadmill test consistently, but I was interested in the trial and I ended up on the advisory board, and I was jaw-dropped to find the amount of studies showing that walking offered hope and relief that we didn't know about. We had no clue about. People think nothing's happening. There was hundreds of them, but they were all small scale. And the biggest reason it would seem that people are unable to participate in these trials is because they cannot walk in a consistent distance twice. So how are we ever going to overcome this if walking is a benefit to patients who are newly diagnosed or further back in it, if we can't actually show any clinical evidence easily to them that this is something that works? Now, I realise this might be out of your remit because it's not at the vascular surgery stage, but it's surely very important that we try to get this going before we get to the vascular surgery stage.
Yeah, that's why, we talked about right before we started this, that maybe possibly studying a structured program versus a supervised exercise therapy program where you have to, have a fully remote system that is scheduled with coaches or going to a facility, like letting people have a little bit more freedom and integrating it, teaching them how to integrate it into their lives with our structured program might be a really impactful study that could include a grander participation group.
Yes, very good question or questions. So first of all, let me just answer the one in the chat, talking about AIDS and sex. The studies that we're talking about here are big effectiveness-driven studies funded by the government. And obviously the government is very keen for anyone to take part in these trials. So regardless of your age, regardless of your sex, gender, protected characteristics, you can take part in these studies. No one is ever going to not let a patient take part in the study because of these characteristics. So if you wish to take part, speak to your doctor, speak to your nurse, and they're going to go through what we call inclusion and exclusion criteria. So I hope that answers the AIDS and sex query. Then, in terms of the walking and the exercise studies, we might be a tiny bit behind there, but finally we've managed to get together as surgeons, as doctors, nurses, podiatrists, etc., with our colleagues who do exercise physiology across the UK. And I'm delighted to say that in the next few months and years, there will be more studies coming out looking at how we can provide exercise outside the confines of supervised exercise therapy. Because we can see already that supervised exercise therapy is just not happening. People are not turning up. The NHS doesn't have money to fund enough clinics, etc. So there is more research coming up looking at non-supervised exercise programs for P.A.D. That's all I can say for now until all of these projects have been funded. But we've been pushing really hard in the last 2 or 3 years to get many of these studies funded. So please watch this space.
And as Tracy is bringing up as well in the chat, we see this a lot across the UK, and it could be that funding issue and, too many patients, not enough time, not enough resources, but and just the cost of treatment. That's why you're doing the lithotripsy study as well, because it is expensive to use a lot of these devices. But she was told no intervention, nothing until her toes actually go black. but I think she says she's in CLI. Tracy, you say you're in CLI, but we talked about this, you know, having it possibly to do with you've been seeing improvement since you've stopped smoking. But you know, we do hear this a lot. Are there any studies, or what are the protocols that are out there for treatment? And I know it varies based on what facility you go to. If you go to London, if you go to Leicester, if you go to Manchester, they're actually more likely to treat you before your toes go black. But because, you know, if you're in that and you do have rest pain, or you do have that critical lifestyle modification, you know, lifestyle limiting claudication, and you really have tried a walking program, you've tried the medicine and nothing is working, they do tend to treat even if your toes aren't black. But that's the exception, it seems, to the rule that we're seeing across the spectrum. In the UK, it's like, well, when your toes are going black, when you have a toe wound that just won't heal, you have a grander infection, well, then we'll consider treating you. But by that time, it's kind of too late. Then it's just a revolving door of these treatments.
Yeah, I think all of these statements do ring true. Is the capacity of the system perfect? It isn't. There are delays, even when you have presented with black toes or with gangrene. I would say that all of us at the end of the day are doing our very best to try and go through the workload, but there are most definitely lots of pressures in the system. And I really cannot know the minutiae and all the details about each case, but all I can say is that every year, I think we are improving P.A.D care in the UK. There's something called a QIF, the Quality Improvement Framework in the UK, where people with CLTI must be treated or have their arteries opened within 5 days, essentially. And about 70 to 80% of certain areas in the country have managed to achieve that in the last couple of years. But of course, we are behind. As clinicians, I think everyone is obviously interested in their patient's best interest, but the pressures in the system are becoming more and more extreme. We're doing our best. That's all I can say.
And I think you've raised an important point there, that if you do have, right, a wound that is not healing and you catch that wound, they are required to treat you sooner rather than later. You said within 5 days.
Yeah,
So
that is very true.
That's important. That's important for everyone to know, because that isn't happening in all cases. We've had to fight and get people to drive long distances to London to make that happen, or to Manchester. You need to say to the doctor, you need to say, hey, you know, I know the protocols that are out there. We need to do something. If I have poor circulation, you know, there are blockages and I have a wound that won't heal. We need to do something about it. It sucks that it does get to that point, because some people take really good care of their feet and they're a toe stub away from amputation. But we can only start with where we're at, and at least we know that's where we are at. And if you do have a wound that's not healing, you do have a right to be treated within, you know, a week of having that. So make sure you do know that. But we have such a great group here. Thank you. I don't want to take up any more of your time, Dr. Sarasas. We would love to do this again. Would love to have someone, if you have a colleague that can come on and talk about their trial and answer more questions, and allow some of our group. This is our hangout that we do each week with our friends in the UK. And, you know, they would love to share some of their stories and feel heard by some of the researchers, you know, such as, you know, Kathy sharing a little bit of her story and her concerns, and Tracy as well. So we appreciate you coming on and letting us know if we can get someone next week, and we can try to line, you know, people up on a weekly basis to just come listen and also share more and try and recruit for these important studies in the UK.
Absolutely. So, Kim, can one of the team get through to me via email through this? I think you mentioned an app of some description. So if you get through to me, I'll get you in touch with every single chief investigator. And this is such a brilliant forum to try and promote how we are delivering research right now in the UK.
Yeah, no, I think it's great. And if they come with even questions that will add, to the research or provide greater perspective, we can also work on some consent forms that if they want, that would be UK approved, that if patients do share their stories when they come in here, they do know that they're being recorded. They do know that this will be live. Those who, if you don't, make sure you message me if you don't want your face shown. For the most part, what we'll try to do is have those who have chosen to speak be the ones on camera, so that we don't have everyone who decides to join ending up on camera. But if you really don't want to be, make sure you do send me a message, because this will be posted on YouTube and in our groups so that other people can learn more about these really important trials. But I'll send you that Calendly link. I'll get that to you in just a little bit, and we'll go ahead and plan forward. But everyone, I'm hoping that you really enjoyed this discussion, and hopefully you continue to join on a weekly basis to learn more about how care is being improved in the UK and the opportunity that you may have to help improve care further in the UK by participating in these trials, but also educating your own physicians and clinicians, your entire healthcare team, that these trials are available. That's really important. Even if you are not a participant in them, it's important that you do raise awareness, with your physician and clinician, your entire care team, that these are available in case they are right for one of their other patients as well. So once again, before we end, Dr. Saratzis, aside from PADtrials.org, which we're going to continue to update on trials, not only in the UK, but around the world, what are those other websites that they can go to?
So vascularresearch.co.uk, which I'm pasting in the chat, is another website where we're trying to upload as frequently as we can some information about these studies. I've just pasted it in the chat function there. So vascularresearch.co.uk, and of course the PADtrials.org, which you have very kindly hosted. Again, I've pasted the email for the KID trial, and do get in touch with us either through the website or through the Facebook group. Very happy to facilitate people's journey in research.
And Dr. Saratzis, I just want to close out here with, again, from the bottom of my heart and on behalf of our entire network of patients with PAD through the Global PAD Association, we appreciate you so much for all you are doing and your passion for trying to improve care for PAD patients. So many doctors may rest on their laurels, and they may say, well, I need more evidence. I'm not going to do this or that without the evidence. But you are creating the change that you want to see. You're listening to these patients. Your team of researchers across the UK are literally helping to create the change that we all want to see. You're not resting on your laurels, which you could very easily say, hey, you know what? I know care's not perfect, but until there's evidence, I'm not going to do anything. But you are practicing medicine. Your teams are practicing medicine and helping to create that change. And for that, we really appreciate you so much.
Thank you all.